Hi, this is Jill Murphy from Contemporary Clinic. Before we get started today, one of our top stories on Contemporary Clinic is about interprofessional communication activities and collaboration between nurse practitioners and pharmacy students. Today I'm speaking with Beth Sandy, an oncology nurse practitioner from Penn Medicine, about oncology nursing. How are you doing, Beth?
Good, how are you?
I'm good. Thank you for joining me. So, my first question is, can you give me a quick overview of oncology nurses and your role at Penn Medicine?
Sure. So I'm a nurse practitioner. So my role is a little bit different than your typical oncology nurse. So, before I was a nurse practitioner, I was a nurse, and the majority of my job as an oncology nurse was to infuse chemotherapy in the infusion suite. Now, as a nurse practitioner, I have a role that's more of a collaborative practice with physicians where we work over in the clinic. I see my own independent clinic each day that I'm there, completely independent of the physician I work with. And then we have a triage oncology nurse who takes a lot of our phone calls. But I also will take some of the phone calls, the sick patients that are coming in for symptom management issues, and see them as well in clinic.
And I saw that your specialty is in lung cancer practice. Have you seen your practice in this change since the emergence of the COVID-19 pandemic, considering it's respiratory based?
Yeah, that's a really good question. And initially, when COVID started, I was really worried for my patients. I was like, oh my gosh, if they get this will be such a problem for them. So far, I've had 3 of my patients who have tested positive. Interestingly, none of the 3 were very symptomatic, which is a surprise because the data suggests that especially lung cancer patients do worse than the average person with COVID. But so far, all 3 of mine got through it pretty well. Most of them were younger, so 2 of them were under the age of 50. So maybe that helped them do a little bit better. I don't know. But the other thing I would say is that my lung cancer patients have also been very extra cautious. So they're not going to parties and they're not kind of pushing the envelope or traveling. They really are scared of the virus. They're staying at home. They're socially distancing. They're wearing masks. And they're just not going out a whole lot because it's actually hard for some of them to wear masks. I saw a patient yesterday, and just walking down the hall with his mask on, he was so out of breath by the time we got in the exam room. He's like, I'm so sorry. And he just ripped it off and was like, and I felt really bad for him. So, the majority of them aren't going out. They're doing a very good job of socially distancing. So far, so good.
And with that being said, and supporting your patients during this time, how do you feel that being an oncology nurse practitioner, supporting patient care, like in your own personal experience, how have you seen that happen?
In relation to COVID or just in general?
Either actually, yeah.
So I would say if you look at it from a COVID perspective, patients have really looked to us as medical professionals to give them guidance. When can I go out? Some patients have stayed in and literally not left their house except to come for their chemotherapy or their immunotherapy treatment. And, sometimes they'll say, okay, well, you can do a couple things, just be very cautious, wear your mask, try to socially distance. I also don't want them going crazy, just being cooped up and not seeing any family members. That being said, we're guiding them to be very smart. Don't go to even a gathering of more than, 5 or 6 people, see family members on an individual basis, make sure the people that, if you're going to see them are also socially distancing. So I think they're just looking to us for extra guidance. If you look at it from a generalized view of how oncology nurses support patients, I could talk forever about that. Again, I think as a nurse in the infusion suite, back when I used to do that, patients would come from their doctor visit right over to the infusion suite to get treatment. And the patient would tell me a whole slew of things that they didn't tell their doctor. I'm thinking, you just saw them. And I don't know if sometimes it's a trust issue where they decided, it's safer to tell us, or, oh, I forgot to tell them. So we are that extra layer of evaluation, reporting symptoms to the doctor. And then I think there's the other part of it too for oncology nurses is we have that nursing background of going beyond the CAT scan, going beyond the dose of treatment, and just kind of being there for hand holding, hugs, just extra support for them. Now, COVID's ruined all that, of course. I can't touch my patient, which has really been a struggle for me, and I think for a lot of people. We do weird things like air hugs, and it's hard. But in oncology, this is, usually, especially in lung cancer, this is an end of life illness often. So these patients require a lot of extra TLC, and I think we're really there for that for them.
And with that being said, moving forward, is there any advice you'd give to other NPs who are looking to break from the oncology nursing field like you did?
Well, I think there's two ways to look at it. If you're going to become a nurse practitioner or an APP in oncology, you don't have to have a background in oncology nursing, but it's really, really helpful. So for example, right now, the patients that I see in clinic, the majority of them are on treatment. So for example, I'm writing their cisplatin order, and I am managing them through their toxicities of cisplatin. It dramatically has helped me as an NP for the fact that for 5 years before I was an NP, I administered those drugs. So I know what it's like to give them and to watch them get sick from them. I know what it's like to give them the anti-nausea drugs and make sure they have the right antiemetics prior to the cisplatin. So that now that I'm in that role where I'm prescribing it and managing their symptoms, I think that just gave me a really good background. Plus, the drugs in oncology are just weird. They're way different from any other field. And it's just helpful to have a background in oncology before you become an advanced practice provider. That being said, there's plenty of NPs and PAs in oncology who did not have an oncology background before they came in. What I would say is, if I think everybody has a reason why they get into oncology, whether they had a loved one with cancer, they want to give back, whatever it is. I think that's all good motivation. It just takes, oncology is just a really different field, and it takes a lot of learning. There's a learning curve with the drugs that we use and just the molecular dynamics of cancer to learn once you're getting in the field, if you don't have that initial background prior.
Absolutely. And my last question for you is, what do you hope to see for the future of nurse practitioners in your community and outside of your oncology community?
I think the continued independence that we have. I mean, we've worked really hard to become more independent practitioners. When I started at University of Penn 17 years ago, I just worked beside the doctor. I didn't see patients on my own. I certainly couldn't prescribe opioids. Now I can fully prescribe opioids. I don't have to get a doctor's DEA signature, and I, run my own clinic. So I think that continued support of a collaborative yet independent practice is really important for us. I think continuing to be professionals as far as presenting, writing, presenting ourselves as independent thought leaders, not just there supporting the physician, but also as an APP being our own independent thought leaders within our field, in addition to our clinical role.
That was great. Beth, thank you so much for joining us. Now let's hear from some of our other MGH Life Sciences brands on their latest headlines.